Thank you very much. I would first of all like to thank the organizing committee for the kind invitation. I am working in Athens, Greece, in the University of Athens in an upper GI department, personally doing around 30 esophagectomies per year. And I think that after the excellent technical presentation of the previous speakers about robotic gastrectomy and robotic esophagectomy, I would like to proceed with a more theoretical subject, the decision-making of how to operate in G-junction cancer nowadays. These are the results of research of the last 20 years, and I would like to discuss three basic questions or dilemmas. Is it better to proceed in the G-junction cancer through an esophagectomy or an extended total gastrectomy? What about lymphadenectomy? Which is the proper lymphadenectomy in either operation? And also, which are the advantages and disadvantages of minimally invasive techniques? So in the case of G-junction cancer, there are two basic options, at least in the European region, because there is a third one, the central, the proximal gastrectomy, which is most often used in Asia. It's a very fascinated operation, technically demanding, and with often some complications when done in Europe. So the most often used operations in our country, and I think also in the Balkans and Europe, are either an esophagectomy, which we can see in the first picture, or an extended total gastrectomy. This is the Sievert classification. It is well known. It is the most often used classification for these tumors, which classifies the tumors in three types, type 1, 2, and 3, according to the epicenter of the tumor, whether it is in the distal esophagus, around the G junction, the Z line, or in the stomach. So in the case of Sievert type 3 tumors, where the epicenter is in the stomach, the decision of the operation is quite easy, because there is plenty of publications many decades now that show us that the lymph node distribution of the cancer is mostly to the distal stomach, to the upper abdominal nodes, and less to the mediastinum. So in this case, an extended total gastrectomy is the preferred operation. On the contrary, in the case of the Sievert type 1 tumors, both for technical reasons, because we have to achieve a proximal margin, as well as due to the lymph node distribution, an esophagectomy, and either an IVOR-U esophagectomy or a total esophagectomy, according to McKeown, is the best surgical approach. The dilemma insists today as well for the type 2, according to Sievert classification, tumors. These are the tumors whose epicenter is around the Z zone. And you can look at this table. This is the table of the index publication by Sievert and Stein around 25 years ago. Those days, most of the type 2 tumors were operated through an extended total gastrectomy. But things look to have changed a lot from those days, because we had plenty of research and plenty of publications showing that in these cases, specifically for type 2 tumors, according to the Sievert classification, there are very low percentages of infiltrated lymph nodes in the distal tumors, in the distal stomach, like is the nodes of station 4, 5, and 6. Instead, there are much higher percentages of infiltrated lymph nodes in the mediastinum. Also, there were quite a lot of studies. This is a retrospective registry-based analysis from the UK, showing that in these cases, specifically for Sievert 2 cases, operating through an esophagectomy offers better survival to these patients. Another crucial thing, and criterion to decide the best operation is the proximal extension of the tumor. You can see this is a typical Sievert 2 tumor in the G junction, and the extension of the tumor to the esophagus, either if it is 1, 2, or more centimeters, is very critical. It is very critical, first of all, because we have to achieve a margin of at least 3 or 4 centimeters in the specimen in order to offer an R0 resection and to offer better survival in these patients. So the longer the proximal margin, the more crucial to operate through an esophagectomy. And also you can see that the distance of the proximal margin from the Z line is the one that determines the possibility of infiltration of the mediastinal lymph nodes. So the longer this margin is, the more often we have infiltrated lymph nodes in the mediastinum, so that we have to do an esophagectomy instead of an extended total gastrectomy. So you can find in the literature algorithms like this one that suggest that in cases that we have infiltration of the distal esophagus of 2 or more centimeters, we have to do an esophagectomy with lymph node dissection of the mediastinum. But is there anybody from the audience that can tell me what kind of Sievert type is this case? This is a case, a very used often case in our patients, where the Z line is totally infiltrated. There is proximal and distal extension of the tumor in the esophagus and the stomach as well. So we can see from the literature that the type 2 cases are the ones that are less often correctly determined from our clinical classifications. You can see in this paper that around 1/3 or even more of cases are wrongly classified as Sievert 2. They're either type 1 or type 3 according to Sievert classification. So it seems that nowadays we have to move from the anatomical classification to a molecular classification of the Sievert subtypes, and you can see that it seems that this zone hosts 2 different cancers. It's either a gastric cancer that moves upward or an esophageal cancer that originates from the esophagus and moves downward to the stomach. So by proceeding with the molecular subtypes, by trying to find through DNA methylation and other techniques the mutations that can that characterize specific phenotypes of either gastric cancer or esophageal cancer, and according to that classification decide the best operation with the lymphadenectomy that has to join the either a gastrectomy or an esophagectomy. So a more modern classification, Sievert classification, may look like this one. You can see this is a molecular classification of the G junction cancer that tries to determine either the esophageal or gastric origin of the cancer. So a few words about lymphadenectomy. Lymphadenectomy in esophagectomy was a matter of debate for many decades. You can find many studies like this trying to determine the better cutoff of the of an effective lymphadenectomy. But like this paper, which comes from Annals of Surgery and determined the number of 23 as a cutoff of effective esophagectomy, or another paper that determines the cutoff in 40 lymph nodes. But it seems like in other organs that it's not a matter of number, but it's a matter of the sites that we operate. It's a matter of stations that we have to take out. So a landmark study was this one. This was an RCT, a randomized controlled trial, that compared the oncologic outcomes between transthoracic esophagectomy and transhiatal esophagectomy. Transhiatal esophagectomy was a very well-used esophagectomy around the end of 1990 and the first years of 2000 around the world. It was an esophagectomy without lymph node dissection of the mediastinum, whereas the transthoracic esophagectomy is the one with the lymphadenectomy of the mediastinum. And what we found is that for those patients that, and these are most of the patients in the Western world that had at least 1 to 8 infiltrated lymph nodes in the mediastinum, operating them through a transthoracic esophagectomy. That means offering them lymph node dissection offers them better survival outcomes. So this was a landmark paper, and since then, most of the centers worldwide have abandoned the transhiatal procedure in terms of lymph node dissection of the mediastinum. Do we have to change our practice in the era of neoadjuvant therapies? Most of our patients in the Western world are operated after neoadjuvant therapies. But nowadays we have quite a lot of evidence that we should offer the same lymphadenectomy in our patients after neoadjuvant therapy. This is a retrospective study from the Netherlands showing that patients that have been operated through with efficient lymphadenectomy survive more, and this is a meta-analysis with the same results. What about lymphadenectomy in the cases that we offer gastrectomy? The evidence is clear here as well. This is a terminology of D1, D1 plus, and D2 terminology, lymphadenectomy. This is a landmark study. This is a Dutch study, an RCT that ran about 20 years ago. About 1,000 patients were randomly assigned to 2 arms. The first arm was offered the D1 lymphadenectomy, and the second one, the second arm, they were offered the D2 lymphadenectomy. And it seems that when we operate using the D2 lymphadenectomy, we offer better survivals to our patients after gastrectomy. Finally, minimally invasive techniques. We watched some great lectures before about minimally invasive gastrectomy and esophagectomy. We can perform laparoscopically and thoracoscopically, doing a totally MIE, a minimal invasive esophagectomy, or the RAMI, the robotic assisted minimal invasive esophagectomy. We can go through hybrid approaches. That means to have minimal invasive the one part and open the other during the learning curve of a surgeon or a center. This is the first important study that showed the advantages of minimal invasive esophagectomy, which are mostly the less pulmonary complications and the less chronic pain. And these advantages are the same in terms of robotic esophagectomy, and these are basically the reasons that we all have to move towards these techniques. And obviously, the survival and the disease-free survival is not different from the open procedure. What we all have to take in our mind and to remember is that there is a cost that our patients have to pay during our learning curve towards minimal invasive esophagectomy or robotic esophagectomy. And these are the anastomotic leak cases in excess that we all have during the learning curve and during the time that we catch up our results of anastomotic leak of the open operation. And you can see here very well illustrated the area under the curve. These are the excessive anastomotic leak cases in a retrospective case from the Netherlands during the learning curve of Dutch surgeons in a minimal invasive esophagectomy program. Thank you very much for your attention.